Dr. Mokshada Kumar, who is a PhD student in Dr. Deval Shah's lab at University of Buffalo.
Thank you so much for that introduction. Hi, everyone. Today, I'm really happy to be sharing my results on development of a platform PBPK model for monoclonal antibodies in pediatric patients and providing some mechanistic insights on how the antibody PBPK is age-dependent, really. So to give a brief overview of my talk today, I'll first be going over how monoclonal antibodies are being used in pediatric patients, followed by some of the challenges that are included in extrapolating doses from adults to pediatric patients. Then I'll give an overview of the main objectives of our study and the approach that we took, followed by some key results, including some NCA analysis and development of our PBPK model. Finally, I'll conclude with future directions. In recent years, there has been significant increase in the use of monoclonal antibodies in pediatric patients. These are primarily being used to treat autoimmune diseases, cancers, infectious diseases, and genetic disorders. Also, in recent years, we have seen much more increase in their use in general within younger populations of pediatric patients as well. However, pediatric patients provide a really unique pharmacological challenge because as they grow in age, you see that they not only grow in size, but also undergo very ontogeny-based changes. Thus, it makes it difficult to then directly extrapolate dosing from adults to pediatric patients. This becomes even more harder because there's very less PK data available in pediatric patients. Even today, less than 10% of clinical trials really include children. Only about 38% of these approved antibodies thus has pediatric indications included. This problem is becoming even higher when you consider even younger patients who are less than 12-year-old, where you see only 28% of approved antibodies having pediatric indications, further lower for infants and neonates, as can be seen over here. In last couple of decades, we have really increased our understanding of how, what processes in antibody PK are age-dependent. So usually antibodies are administered intravenously or extravenously through subcutaneous or IM injection. Once they are administered into the body, if administered extravenously, they then enter systemic circulation via lymphatic blood flow. So any changes in lymphatic blood flow would then affect their absorption process across age. Once inside the blood, they then distribute into various tissues and largely are present within the tissue water present since they are very hydrophilic in nature. Studies have shown that pediatric patients have much higher per kg tissue water content as compared to adult patients. Similarly, the perfusion rate would really impact how much antibody is distributed into bodies, into the tissues, and studies have shown that pediatric patients have higher perfusion rate as compared to adult patients. We also know that increased capillary permeability could lead to a higher distribution in pediatric patients, and we know that up to 4-fold higher capillary permeability exists in infants and neonates as compared to adults here. Once inside the system, our antibodies are primarily then eliminated via non-specific catabolism, via target-mediated drug disposition, or immune complex formation. Now, FcRn is a receptor present in our body, which plays an important role in salvaging monoclonal antibodies. And studies have shown that pediatric patients may have higher concentrations of FcRn as compared to adult patients, and also that pediatric patients usually have lower concentrations of competing endogenous IgG as compared to adult, which would all really indicate that there might be changes just beyond body size that would affect then the antibody PK, and makes it important to understand how these processes really affect antibody PK in the bigger picture. There has been, as a result, because of a lack of understanding of the quantitative amount in which these processes affect antibody PK, there has been a lot of lack of consensus, which is highlighted by this compilation from University of Florida, where they show that while alemtuzumab is reported to have more rapid clearance in children as compared to adults, you see that antibodies like basiliximab have been reported to have lower clearance in children, while others like bevacizumab are reported to have no change based on age on their on their clearance. Thus, we see that there is a lot of conflicting reports, and which results really in very varied dosing strategies being used for pediatric patients. So if you are dosing drugs and antibodies in adult, you really don't know which one of these approaches is the best to go forward. This brings us to the objective of my study, which was really to evaluate the impact of age on antibody PK and identify platform strategies. The approach that we took was to expand our antibody database, conduct a comparative analysis of pediatric and adult patients, and then go on to do a pediatric PBPK model development, followed by formation of our Shiny app, which was used to support easy use of our model developed. So we expanded the adult database to pediatric patients and collected a lot of PK data from literature, as can be seen over here. Once we had collected this data, we really wanted to check and answer the question if there are any changes beyond just body weight. So to answer this particular question, what we did was that we dose normalized all of the collected data to 1 mg per kg dose, and then really overlaid these data on top of each other to see that beyond body weight, are there any further changes that are seen. Our analysis really showed us three major aspects. So for pediatric patients that are less than 2 years of age, we see that for the same per mg per kg dose, we see much lower exposures in pediatric patients as compared to adult. In contrast, if you were to see patients who were about 2 years of age, up to 18 years of age, for antibodies which exhibit linear PK, you really don't see much difference in PK, and you can see that the PK really overlaps between pediatrics and adult patients. In contrast, if you were to see antibodies which exhibit TMDD, you would see that pediatric patients show much lower exposure at the same mg per kg dose as compared to adult. This really highlights that your TMDD processes can be highly age dependent and really need to be taken care of. This is further confirmed by the result that if within these TMDD exhibiting antibodies you give higher doses where they show linear PK, then the PK really starts overlapping with that of adults, further highlighting that TMDD is a highly age dependent process. For antibodies like dupilumab, which are given extravenously, we also see that we see higher absorption take place within these antibodies. These results were further highlighted by NCA analysis, where we saw that pediatric patients have higher VC per kg and also have higher clearance per kg in pediatric patients. To incorporate all these changes, we then developed a pediatric antibody PBPK model, where we also used the basic structure the same as adults and incorporated a lot of physiological parameters that changes with age. By incorporating all these parameters, we were then able to really characterize the PK of various antibodies across different age groups reasonably well, as can be seen over here. Our model is currently able to do that for 13 different antibodies. And we have also validated our model by using sparse antibody PK data, which was available and not used for model development. And as you can see over here, we were able to predict a priori the PK of antibodies at different age groups reasonably well. We've also incorporated this model into an Shiny app to then make it easier for clinicians to use this model to support dose development. To summarize, we did an analysis where we saw that pediatric patients show changes in PK much beyond just body weight based changes, and we were able to develop an PBPK model to account for these changes and characterize PK of antibodies in pediatric patients from 0.1 years to 18 years of age. In future, we hope to incorporate other age dependent changes as well. I would like to thank all my lab members and also all the funding sources. Thank you.